ahead.
The broadcast is now starting. All attendees are in listen-only mode.
Welcome, everybody, to this webinar hosted by SPR, CEPI, and Division 29 of the Society for Advancement of Psychotherapy of the American Psychological Association. I'm Sam Nordberg, and I'll be co-hosting this with John Mellor-Clark. And we'd like to begin just quickly with some instructions for our audience as to how you can participate in this webinar. If you look at the dashboard that you have, you will notice that there is a questions section of that dashboard. You are welcome at any time to type technical questions or questions for the panelists into that area. Those questions will then go to me, and I will hold those questions until an opportune moment and bring them up for the panel to address. There's also an opportunity for some dialogue back and forth in the last 30 minutes. If you'd like to engage in some dialogue and you have a question, please write that in the questions panel, and I'll make sure to put you in the queue for our 30-minute discussion in the last half hour of this presentation. During that discussion, we have the opportunity to open up your microphone and allow you to speak. So please make sure that if you do have a microphone, you're close to it and you speak loudly and clearly. With that, I'd like to turn things over to John for a brief introduction, and then we'll get started.
Hi, thank you very much indeed, Sam. Hi, everybody out there. This is my very first webinar, so please bear with me while I get used to speaking to both a silent and invisible audience. A few introductions first to both ourselves, Sam and I, then an introduction to the event, and then I'm going to ask the panel to introduce themselves, tell you a little bit about the service that they're implementing routine outcome measurement into, the systems that they're introducing, and where they're talking to you from. So firstly, myself, I'm John Mellor-Clark. I've been an evaluator of counseling and psychotherapy for a good number of years now, some 25 I think this year or next year, and I'm fairly passionate about the potential of routine outcome measurement and, once collated, the potential and indeed value of practice-based evidence to science. But I'm very, very well aware of how difficult it is to implement routine outcome measurement and to engage and excite and enthuse and keep engaged clinicians. And I got talking to Sam about this, and that was the beginning of this seminar. So I'll say a little bit more in a moment after Sam says a little bit about himself.
Sure. So I have much less pedigree than John does. I'm much newer to this field, but I currently sit as the Director of Behavioral Health Informatics and Innovation at Harvard Vanguard Medical Group, which is a large multi-specialty practice serving about 1 million patients in Massachusetts, and they have a very large behavioral health division that I'm currently rolling out routine outcomes monitoring for. I've developed helped develop a couple of measures and supporting tools for those measures, and I think one thing that I do share with John is an ongoing passion for and belief in the value of routine outcomes monitoring.
That's great. Thank you very much indeed, Sam. And actually, it was those passions that that collided when Sam and I found ourselves at the same event in Førde in Norway, talking to clinicians and doing a day seminar on the introduction of routine outcome measurement and its value and how it can be incorporated into practice more as a clinical skill than an administrative activity. And that idea grew into the webinar today. So firstly, in the literature, it's quite important to recognize that there has been a few papers recently that have appeared that have begun to share and collate some of the experience that's going on. Sam, if I could just ask you to flip through the slide here to the third slide. Okay, so this is a paper by James Boswell, who I believe is amongst the audience actually today. David Krauss, Scott Miller and Mike Lambert. And together I think that what they set out to do, which was very brave, was to compare the scars of introducing routine outcome measurement. And that paper, I think, was quite inspirational for many to come together and to start to share their experience. And last year in September, there was a special edition of the Administration and Policy in Mental Health and Mental Health Services Research Journal, which looked at the personal experiences of many introducing outcome measurement systems. So Len Bickman, Susan Douglas, who Susan's with us today, Miranda Walport and colleagues from the UK introducing children and young persons, IAPT, Kim DeYoung and colleagues introducing OQ suites and various services for research, and indeed our own core team here in the UK. And what was common in all of those papers to some extent was this overarching realization that whilst in the diagram here that's a summary really of the Boswell paper, that there's lots of evidence to suggest we really do need to be and could benefit from introducing routine outcome measurement, that there is a significant amount of resistance. So this is a force field analysis with the green arrows pushing in from the right, showing you a summary of the evidence and the rationale for introducing ROM, and then looking on the right, the pushback, if you like, from practice, which really challenges researchers, managers, clinicians, and others when they come to actually implementing it. And so the idea of today was Sam and I were well aware from our own networking, from connections that we had, from research that we were involved with, that there were services out there that were having a lot of these experiences, but actually were overcoming them and finding in some cases quite creative ways of overcoming them. So what we did was we put out a call to those services that we knew of and said, look, we'd like to bring together a unique panel, not at a conference, but as an international webinar so that people don't have to travel. And we'd like to bring together the experience of people to focus on two particular areas, and that is how do you secure service-wide clinician enthusiasm, and then secondly, having secured it, how do you actually use data from routine outcome measurement as practice-based evidence, how do you use it both clinically and managerially to actually make a difference. In our own experience, both Sam and I, it's too common and it's too easy for some extent for measurement to be relegated almost to an administrative activity that is done more to be seen to be doing the right thing than actually to inform you whether you're doing the right thing and whether it's making the right difference. So when we came to advertise for the event to participants, we were a little richer and talked about the key themes that really came out of James's paper, which was clinical resistance, logistical resistance, and insecurity. And so our intention today is to focus around about 15 minutes on each of those areas and to invite comments really from our panelists to identify with some of those problems, to volunteer into sharing their experience of those problems, and more importantly, share how they've overcome those problems and what for them has made a difference. In the unlikely event that for our panelists that experience sort of dries up, then both Sam and I will happily contribute our experience and talk on behalf of both panelists and others that were not able to be present and share, but I doubt that that's going to be necessary. In addition, at the end of each of those sort of 15-minute sessions, Sam and I will summarize what's been said, and then at the end, as Sam said earlier, what we will do is to just ask for questions to help us through the last 30 minutes, where people from the audience today can ask our panelists questions, etc. Now, hopefully, all of this may seem pretty smooth and pretty well organized, but actually this morning both Sam and I woke up to an email from one of our panelists pointing out that whilst you may have all the planning, pre-thinking in the world, and think that you've got your methodology absolutely right, it only takes one variable to actually tip you upside down. And both Sam and I this morning were tipped upside down with the one variable, and that was we had oversimplified world time and the management of it. We'd actually advertised this event, this webinar, as starting some 1 hour after we had advertised it in the US to start. We'd not accounted for daylight saving time, and therefore our your UK and indeed our European counterparts and panelists today were thinking that they were joining this event at 3 o'clock UK time or 4 o'clock Central European time, when in actual fact it was earlier. So this webinar today is really about, it's a naming event. These are the final things I'd like to say. It's about naming elephants in the room. Sometimes these are baby elephants. Sometimes they're mere elephant shadows rather than present and dangerous elephants. Sometimes they are big elephants, and that try as we might, we just can't ignore them and their presence. And so I'm firstly going to name our first element of Dumbo, because after Bill's news this morning, that's exactly how Sam and I were left feeling, and we've named our first elephant. It is and was an error, and for anybody that's been tripped up by that or inconvenienced by it, both Sam and I would like publicly to apologize for that. So having made those introductions, set the scene for today, what I'd like to do is to introduce now our panelists, or invite our panelists one by one to introduce themselves. And again, the brief in the introduction is to say where you're speaking from as a country and indeed as a service, what service you're introducing ROM currently into, and what measurement system that you're using, so that our audience today can get an idea as to the spread of experience that will be shared today. So with no further ado, I'll mute my microphone and ask Auden if he would please introduce himself.
Hello everyone, can you hear me?
Yes, you're fine, Auden. Go ahead.
Ah, brilliant. Okay, my name is Audun Røren, and I represent Solli Distriktspsykiatriske Center in Norway. Solli is a psychiatric hospital with both inpatient clinic and outpatient clinic. The measurement system we have experiences from implementing is CORE. And I am the administrator of CORE here at Solli, as well as I'm working here clinically. So we have our experiences is from implementing CORE in our group-based outpatient clinic.
That's great. Thank you very much indeed, Auden. Thank you. Ben, if I could ask you to introduce yourself.
Sure. Hello and good morning to everybody. So my name is Ben Locke. I'm at Penn State University in Pennsylvania of the United States. I hold two roles here. One is my first role would be as the Associate Director of Clinical Services in a large college or university counseling center. We see about 3,500 students a year here. And then the second role would be as the Executive Director of the Center for Collegiate Mental Health, which is a national, now international PRN that standardizes and pools data from college and university counseling centers. So I can speak from a kind of a large-scale perspective on the order of 100,000 clients and several thousand clinicians to my local experience here in our counseling center, where we have about 50 individual providers, about 3,500 clients a year, and the Center for Collegiate Mental Health manages an outcome tracking instrument called the CCAPS, the Counseling Center Assessment of Psychological Symptoms, and that instrument is what we have implemented on a routine basis here in the counseling center.
Fantastic, Ben. Thank you very, very much indeed. Bill, if I could ask you to introduce yourself.
Hello, everybody. I'm working on Irish Sign Language.
Bill, if you could speak up a bit, you're quite faint.
All right. Can you hear me better now?
That's much better,
Hello?
Bill.
Yeah. Okay. So my name is Bill Andrews. I'm the
coordinator and administrator of the Pragmatic Research Network, which is a network comprised primarily of independent practitioners in the UK. Originally inspired through the work of John Mellor-Clark with CORE, and also Scott Miller, particularly in the States. Did a lot of training with Scott in implementation of feedback-informed treatment. And I've been running this practice research network now for about 8 years, and I've got involved with various other organizations in implementation as well. And the tool that we are now using is one I've developed myself with a colleague called Pragmatic Tracker. That's probably enough for now.
Thank you very much indeed, Bill. That's brilliant. Carrie, if I could ask you to introduce yourself.
Thanks, John. My volume clear enough for you?
That's perfect, thank you.
Hello?
Hello, that's perfect.
Great, thanks.
Very good volume.
My name's Carrie Montgomery. I'm coming in from Belfast in Northern Ireland. I'm the Director of Operations for a counselling organisation called Contact, and the major project that we deliver is called the Lifeline Service, which is a suicide prevention crisis counselling service available to the whole population of Northern Ireland. We went live with CoreNet in September 2013. And really that was following a paper-based trial, so I'm hoping to contribute quite a bit to the clinical resistance. My background itself, I'm a licensed clinician. I've been practicing now for coming on 15 years, but as I say, my current role is as director of the organisation.
Fantastic. Thank you very much indeed, Carrie. Look forward to hearing more about that clinical resistance journey a little bit later. David, if I could ask you to introduce yourself.
You bet. Dave Ross here from Montreal, Canada. I work for Veterans Affairs Canada. I'm wearing a couple of different hats right now. I'm the acting manager of the Operational Stress Injury Clinic Network. That's 10 clinics currently, will be 11 as of the fall. We're looking at about 220 clinicians. I'm here today because I'm also the lead for the CHROMUS initiative. This is a web-based outcome monitoring and management system based on the OQ45, the PCL, the WAS, and a couple of other instruments that we snake in from time to time. But basically what we do is we ask our clinicians to use that on a session-by-session basis and to give the feedback directly to the clients, and to basically to integrate outcomes management into their clinical practice.
Fantastic, David. Thank you very much indeed. Look forward to hearing more about that later. Kim, if I could ask you to introduce yourself.
Yes, my name is Kim de Jong. I'm an assistant professor at Leiden University. Although I'm a researcher, I've also been working in a mental health care institution as an applied researcher for about 13 years. And one of my major tasks was also to assist the implementation of routine outcome monitoring, which has become mandatory in the Netherlands about 5 years ago. My research is mainly done with the OQ45, but I also have experience implementing the SDQ, which is the Strength and Difficulties Questionnaire for youth and young persons, and the BSI, which is the Brief Symptom Inventory. So I have sort of a wider experience than I'm probably known for.
Thank you very much indeed, Kim. And now, Kim, in Denmark, if I may ask you to introduce yourself.
Yes, hello, I'm Kim, and Sam, if you want to practice my last name, is pronounced Kjærgaard. I'm the operations manager for Tuba Denmark, and I'm also the admin of the Tuba CoreNet system that we implemented on January 1st, 2014. Tuba is a psychotherapeutic counseling for young people between the age of 14 and 35. Who grew up in families with one or two parents who have alcohol or substance abuse. Tuba helps around 4,000 clients a year, and we complete about 20,000 sessions. Yep, we implemented the CoreNet system on 1st of January 2014 after spending around 1.5 years before that preparing our thoughts and strategy for implementation of routine outcome measurement in our therapeutical counseling. The measures we work with are completing start and end evaluations for our clients are the Core 34, the PTSD 8, the MDI, the WNSAS, and then a fairly large amount of our own questions designed for our clients. We then use the FIT, the Feedback Informed Treatment from Scott Miller, as an evaluation system that we complete for each session held in Tuba. Yeah, I think that's it, yeah.
Thank you very much indeed, Kim. And now, Susan, if I could ask you to say a little bit about yourself.
Sure. My name is Susan Douglas. I am a licensed clinical psychologist, a program evaluator, and faculty at Vanderbilt University in Nashville, Tennessee in the States. And I represent Contextualized Feedback Systems, or CFS, which was developed here at Vanderbilt by Len Bickman, myself, and others on our team as well. Between about 2005 and 2014, we had it implemented across the country in almost all 50 states, in community mental health centers, and serving youth with mental health difficulties. The measures that we used, we had developed ourselves, called the Peabody Treatment Progress Battery, and that is a battery approach to routine outcome monitoring for youth that includes brief measures on symptoms and functioning, satisfaction with life, caregiver functioning, and some of the strengths-based or common factors about the treatment process, like child hope, motivation for treatment, and some other things. And as of 2014, we no longer have the electronic system, but we still do have that battery that's available.
Fantastic. Thank you very much indeed, Susan. I know later again you've got a lot of experience to bring and share, so it's great that you're with us today. And finally, Tommy in Sweden, if I may.
Yeah, I'm Tommy Schulsvik, and I'm a clinical psychologist and researcher, and I've been implementing CoreNet in secondary care in about 10 services in the western part of Sweden. Yeah, maybe that's about it.
Okay, thank you very much indeed, Tommy. Anything, Sam, that you'd like to add before we get going with asking our panelists to share some experience?
No, let's cut to the chase. And you know, people in the audience, as questions come to you, feel free to type them into the questions panel, and I'll make sure to get them in a queue for asking questions either during some of our structured discussion or later during our more dialogue-oriented portion.
Fantastic. Well, thank you very much indeed, Sam. Okay, well, there's 3 areas that we're going to be looking at over the next 45 minutes. We're planning to give around about 15 minutes to each, but if some of the areas have less detail to them and are shorter than that, we won't worry about that because it'll leave us more discussion time at the end. If I can remind you again for the audience, the 3 areas that we're going to look at are specifically clinical resistance, logistical resistance, and finally insecurity. So under clinical resistance, what we're talking about is the common experience that services, researchers, managers, clinicians have. Can I just say that we've got quite a bit of noise on a microphone, and if that person could just mute their microphone, that would be great. Okay, it's all gone silent again now, so that I'm guessing that the audience can hear again. So clinical resistance, with the sort of experience we're talking about there is where you suggest the idea of introducing routine outcome measurement, which is essentially a measure such as the OQ or the PCOM system, ORS and SRS, or CORE or OQ. You suggest that clinicians use it routinely at every session or perhaps every monthly session. If you're doing longer term therapy, and the response that you get from the clinicians is that my patients or my clients won't like it. What about the transference issues? It'll get in the way of the alliance, or it'll lack clinical value as a process, so why do we need to do it? Those are the typical areas, and what I'd like to do is to just now open up the floor to our panelists to each of them that have had an experience of that to share the problem that they had when, as implementers, they were bringing the idea to their clinicians and some of the things that stood in the way of that. We'll then move on to look at some of the solutions that helped overcome that. So if I could just ask anybody in who'd like to share to open their mic and say something on that.
I'll maybe contribute to this point, John. We, in Contact in Belfast, we had really taken the approach of, we were aware we had undertaken a pilot by using the core tool on a paper-based system, and that was, I would say, about 50% of the time it was used within the counselling sessions. During that pilot phase, we had asked staff really we're a brief solution focused short-term model, so on average we would provide 4 to 6 counselling sessions for each of the clients coming through for our services, and we asked that they use the tool during the first, middle and end session, which was really session 1, 3 and 6. What we found was the returns that we were getting from this tool were mostly for clients who had completed a full course of treatment. So that immediately sparked my interest in terms of what was happening to the clients who weren't coming through to the very end of their treatment program. So we really took it slowly with our staff to introduce the online system, because our intent at that stage was to have every session client counsellor evaluation. And we initially brought John Mellor-Clark over to our International Suicide Prevention What Works conference in September 2012, and that was really to begin the process and begin the discussion, not only with our own staff but also with the wider suicide prevention field in Northern Ireland. That was followed then by a more dedicated workshop specifically with our own staff internally, and again John and his team came back over and spent a day working with our staff and in a very engaging way really put all the common areas of resistance out front and opened them up to discussion. The next step really that we felt that it required a whole leadership buy-in, and for that purpose we decided that it would be our clinical managers who would be trained up to deliver training on the system to our staff, so again they could work intimately with their small staff teams, knowing them very well, and work through any of the possible resistances that might have come out, and all of the aforementioned, all of the stereotypical resistances that came out during those small team meetings. So really it wasn't until September 13, so we'd had an 18-month lead-in to this, that September 13, and it was mandatory for all of our staff to complete a core outcome measurement for every session. And we scrutinised this basically against, we also have an online system that records all of our client contacts, so we were able to cross-reference and ensure that there was a core outcome measure was being completed for every session that they were getting paid to deliver.
Grand. Carrie, thank you very much. Indeed. I remember the implementation well, and I think what you're talking about there, what you're talking about is a very progressive approach that on paper had a sort of 12-month lifespan, and then the rolling of the electronic systems sort of something like 18 months, so 2.5 years in total before it became part and parcel of the culture, and you were confident that you were getting the sort of quality of data that you were that you're wanting, etc. So and what you're describing as a methodology is that there was an event that was a winning of the hearts and minds, if you like, that tried to dispel some of the myths, and then went on to try to explain to people, find out from people what stood in the way of them engaging with this and embracing with this and working through it methodologically. What I'd like to do is to ask any other member of the panel who has an experience of introducing a different measurement approach, what their experience was, if you would, so we could get a balanced approach.
If I can say something, I can add something, I think. We have in the Netherlands a situation that I think is different from what most of the people here have, and that is that it's become mandatory for mental health care institutions to measure, and not only has it become mandatory, but it also goes to a trusted third party who then benchmarks results, which has both been, I think, in terms of implementation, an advantage and a disadvantage at the same time. The advantage being that there was some pressure actually to make sure that the implementation took place, as because the mental health care institutions were actually cut in their budgets if they didn't make the targets by the insurance companies. So, but you can imagine that that also, that kind of pressure also creates a lot of resistance, and it's also an approach that is, it gives an idea to clinicians that the measurements are not being used to help them, but to help hold them accountable. And so I have struggled a lot in the implementation process to sort of turn it back to an aid to the clinician and sort of find a way to motivate clinicians to use it in clinical practice as a tool to help them provide better care to their patients. And so my approach has mainly been to stay close to what motivates a clinician, and that is helping their patients. And so you're already hearing it a bit in the way I present this, is that I talk to clinicians when I'm, for instance, giving a training about using feedback measurement systems or routine outcome monitoring as a tool for them to help their patients get better. And I explain to them that they have their blind spots, and that, as you already mentioned, John, we really do need these extra measurements to aid the clinical view or the clinical experience of the clinician. And the other thing I've been doing is that what I've been trying to make an open subject is that it's not always pleasant to get these measurements, because sometimes your patients do not progress, and that's not always nice as a clinician to hear. And what I've been trying to do is to make that an open subject, because sometimes clinicians have fears that, this implementation will show that I'm not that good of a clinician after all. And that is something that can cause resistance in my experience.
I think you've named probably one of the largest elephants in the room, and that is the performance anxiety, I think, of clinicians. I think that the idea of routine outcome measurement gives us something that we probably not had before, and that is much more robust data in terms of representativeness as to a much greater proportion of outcomes. And I think that the reality is, if you asked any clinician, would they like to know their outcomes and quantify their outcomes, the answer would be, for many, perhaps. And the second thing, the question that they would probably ask is, well, how are you going to measure that? And, one of the challenges that we've got, of course, is that by making measurement more routine, we have to make it easier. And often people perceive easy as being brief, And then the challenge is that we use ultra-brief measures to measure a very, very complex process. And what it turns into very quickly is an administrative process that is done because it is about accountability, and we lose the complexity of measurement, and thereby we create some rift, I think, and some gap between the complexity of clinical therapy and the complexity of measurement. We oversimplify measurement to strip it of its greatest clinical value. So I've read of your work a lot, Kim, and I'm very aware that you know, that you, like myself, and indeed like Sam, are passionate about building the complexity and building the value into a measurement, and seeing measurement very much as a clinical activity rather than an administrative activity. And you know, I think that that's an admirable approach, and more of us need to be building the clinical complexity into measurement. It stands to reason that if you measure yourself every single session, you're going to find out things that perhaps you don't want to know. And what the practice-based evidence tells us, and this is one of the other elephants in the room, is that with these brief measures, around about a quarter of people will be showing levels of clinical and or reliable change, and that means we live with the discomfort of thinking that for 3/4 of people we cannot show evidence that we are helping, not with the sorts of brief measures that we are using, and not with the amount of attrition that we experience with people, working with people from psychological therapies. We've just got a few more minutes left on this particular subject, and I think that what we're doing, and I blame myself for this, is hearing the accounts and interpreting them and commenting on them as they go along. So I'll try to do less of that in the next session. But if I could just have one more panelist perhaps comment on working with resistance from clinicians and how they have overcome that. And again, I think we've heard of OQ, we've heard of CORE. If there's somebody that can speak up on a different measurement approach, we are looking for common factors here at the end of the day.
John, this is Ben Locke at Penn State. I'm happy to offer a couple quick thoughts here. We use the CCAPS, an instrument that was actually developed by staff in a counseling center and is now used in college and university counseling centers. And I think the relevance of the instrument to the people being treated is really important. When clinicians perceive that an instrument is not close to their clients, I think they're much more willing to reject it up front. And just a couple thoughts on the kind of clinical resistance and then how we've dealt with it. I've trained both our own staff here, about 50, and then probably a dozen other institutions, institutional counseling centers. I see clinical resistance falling into kind of 3 categories, and I think Kim's comments very much parallel my own thinking. The first is that the concept of routine outcome measurement is not a clinician's concept. It's a researcher's concept. And when I talk with clinicians, we talk about the instrument as a clinical tool to aid in their decision making, not to evaluate their clinical work. Clearly it does both, but I think when you're trying to speak with clinicians and you refer to monitoring their outcomes, you immediately launch sort of a defensive reaction. For clinicians who've been around for a while, I think there's a cluster of resistance around what's unknown, confusion about it, how is this going to work. There's a lot of reactivity around the client. How is this going to affect my clients? I worry about what the impact will be on my treatment, on my therapy, on my relationship. But probably most importantly, as we all know, aggregate data, averages, average change curves, etc., do not capture all clients, period. And so, yes, a client may be an X, Y, or Z bin or may change at such and such a rate on average, but you may have that client who has entrenched depression with a bunch of other factors that are keeping them there, or a peak on social anxiety that just isn't going to shift even though everything else gets better. And or the client who is actually functioning 80% better, but whose scores haven't really changed because they're still very symptomatic. And I think that then brings up the fear of evaluation. When you phrase it as routine outcome monitoring or something of that ilk, then that's a researcher's administrative perspective. I think the clinician might have real genuine worries about being evaluated with clients who don't fit the mold. And then also there is an unreasonable fear or paranoid fear of evaluation that some clinicians experience. And I think Kim's comments earlier really cut to the chase that we need to think about developing and implementing clinical tools to aid in the clinical work rather than evaluating outcomes if we're trying to bridge with clinicians. I'll stop there.
Ben, those are excellent comments and ones to me that are extremely well made and resonate extremely well as well.
And John,
I think that what you're saying.
There are a couple of relevant questions that have come up that I think we might just ask right now.
Okay, that's fine.
That fit quite nicely with this. And a couple of the questions really come in line with the idea that measures may not work for everyone, and the concern, a clinical concern, that some clients may quote unquote game the measure, right? They may falsely report, and how do we talk to therapists about that, and how do we account for that? And then another concern that really struck several of our audience members was the concern about how do measures work with different cultures and different sort of sociological constructs that may represent symptoms very differently, may consider disorders very differently. So those two questions are out on the table for the panel.
I think they're good questions. I can hear somebody thinking.
Yeah, this is Dave Ross from Veterans Affairs. With respect to the first question, I mean, can people game client self-report measures? Of course they can. These instruments are only as good as your relationship. And this is one thing that we made quite clear as we were discussing it. And one of the things we did before we implemented was we actually polled our clinicians in depth across the country to see what their concerns were and what they would like to see. And this was particularly an issue for us because in Veterans Affairs we have people who are receiving benefits, so there can be a financial incentive to looking more impaired. We basically made some very clear statements about that the data would be used in a formative, not a summative manner, and that the system would only be used on the basis of informed consent. So the only veterans who are using our system are ones who have been fully informed about its use and its limitations. And we found that was quite helpful because I think that's an issue that needs to be dealt with directly. It's only a tool. It's only a measure. It's not the answer.
And that's a point very well made, David. Again, interpretive rather than summative training is absolutely key. How you introduce systems, what they're promoted as, the job that they're set out to do, absolutely key to understanding and trying to make sense of the complexity of measurement and to reduce concerns. The second point that was raised, Sam, was, if I'm right, concerns about how measures work with different cultures. Is that correct?
That's correct.
And again, are there any of the panelists that have got anything they'd like to contribute to that question?
I can offer just very quickly in the U.S. This instrument is in English primarily. We're looking at translating it. When it has been translated, for example, to Chinese, the factor structure doesn't hold up. It changes. It's also different in Thai than it is in Spanish. And we know from clinical experience in the U.S. that especially international students from, say, China interpret some questions in ways that are just very, very, very different and inconsistent with their intent, and they produce artifactually high scores on certain subskills. And just to make a comment, kind of tying this into something previously, we strongly encourage clinicians to review each of the subscales and then to have a direct and ongoing conversation with clients about reporting honestly, reporting based on today, agreeing on the time frame that they're reporting on, and sometimes a discussion around authenticity, being real with what you're experiencing, results in a dramatic increase in severity, because now the person's actually reporting what they're truly experiencing versus what they think they should report. And those kinds of changes as a result of integrating this conversation into clinical practice may not always reflect an RCI or a positive outcome, but are absolutely a good clinical outcome.
I very much agree with that, and I think that using the FIT in Tuba in Denmark, the FIT system, that's where we had most problems with implementing it with our therapists, because a lot of them, especially using the SRS, the session rating scale, a lot of them said that this has to do with the relationship between me and the client. This has to do with the allegiance, with the alliance from me to the client, and they won't say anything negative about me because I'm still in the room. And what we found was that it wasn't actually as much a question about believing in the system or believing in the measure, as much as a question of being willing to open up and speak about the culture that's a part of being a psychotherapist, a clinician psychotherapist, at least in Denmark, because the culture around working as a clinician or a psychotherapist is that you go into your room and you close the door, and you're not used to anybody asking the questions. So I guess that what it did for us was that it actually helped open the doors into the clinician's room, and helping them to just start to put some words into what is it that is difficult for me working with this, and what kind of culture am I facing that I've been working with for 20 years, and what is implementing these measures actually challenging for me? What part of that culture is that challenging for me to use to work with? So I think that was a real eye opener for us implementing the routine measurement.
Kim, I think that's a fabulous point, and it's one that reminds me of something that can be useful in working with clinicians, which is talking about the collaborative and learning opportunities that can also arise from clinical feedback. And one thing that we're trying at Harvard Vanguard is, in some respects, using clinical feedback to drive peer consultation and grand rounds discussions of particularly, or cases that look, according to the data, to be particularly challenging. So John, I realize that we need to move on, so I will stop now.
Thanks, Sam. That's really good. A rich discussion, some very relevant questions, I think, being raised by the audience there. What I'd like to move us on to is the flip side of the coin, really, and indeed the next biggest problem that is identified both by chatting to other researchers, to other implementers, to service managers, and reading the papers that are beginning to come out, bearing the scars as to some of the challenges of implementation of the coalface, and that is the use of data. The insecurity that pervades, really, services, clinicians, supervisors, when it comes to the use of data. And I know that many of the panelists have got really good experience of overcoming some of these challenges. And again, what I would like to do is just open up the microphone and to ask the panelists to share their experience of some of the problems that have arisen for them in using data, and how they've overcome those problems and made data meaningful within their services in a way that is engaged clinicians in using the data, reflecting on it, whilst at the same time meeting the needs of commissioners, of managers, of payors, to have data that makes their service transparent. So again, opening up the mic to anybody that might have some experience to share here.
I'll maybe contribute to this, John.
Carrie, yes, thank
Sorry,
you.
Kim, are you? Yeah, sorry, two of us coming in at the same time. Really, from our services perspective, we had introduced, it was interesting just the last question as well, around culture and what is, I think there's obviously cultural barriers that may need to be overcome with client base, but also internally, what's the organisation's culture? So for us, this measurement was introduced at the same time that we had gone to a paperless system. So everything within our organisation was available to any of the clinical management team should they want to take a look at some of the work that the clinicians were delivering. Our service, it's a hotline, it's a suicide prevention hotline, so the first point of contact is that somebody will come through to the telephone-based service, and about a third of the clients will be recommended on to brief solution-focused face-to-face counselling. So about 6 months prior to introducing the core system, we had introduced a client information management system, which also required that all of our counsellors, 200 counsellors based in the field peripatetically, they were required to upload their clinical notes real time, because should a client then subsequently call through to the crisis line in suicidal crisis, we needed to have all of that information dynamically available to help inform our intervention. So we have been very much scrutinised, not only as the service that we deliver, it's very much in the public eye, it's scrutinised, but also by our funders. And from our perspective, data quality was a key issue, because we're ultimately working towards reducing the suicide rate within Northern Ireland, and any of the gaps in data could have made a misinformed clinical decision. So we were looking towards really very good quality data compliance and real-time data compliance. So this spread on into not only our call information, but also then the clinical information. We would on a daily, a weekly, a monthly basis, we would review all of our data to test for 100% data compliance. And if there's any issues around that, then we would put in additional training measures. Not only do we scrutinise internally, but we're also scrutinised by our funder externally, and they were very interested in cross-comparing our own internal client information management system with the data that was produced through the CoreNet system, as they're two sort of, they're run separately, although both online. So if we didn't pick up on any data incompleteness, our funders were certainly going to on a quarterly basis.
Carrie, that's very useful, and again, I'm very aware of what you've been doing and what you've been achieving, which is an amazing accomplishment. Again, for I think the purpose of the audience, and just quite briefly due to time, what do you find the clinicians now giving you as feedback as to the value of the information that you are giving back to them from their efforts to measure outcomes?
It does very much inform our work. I mean, we unfortunately, because of the client group that we're working with, we would lose to sudden death about 30 of our clients on an annual basis, which is very concerning from us, right from the front line through to the management tier. So from their perspective, really the buy-in for them was, if we, with the data analysis, can add any value to improving the services that we deliver, you know, that really that's our purpose. It's a just clinical culture, it's not a blame culture, and that's been the organisational culture that we've been working within for the last couple of years. So the information, the counsellors themselves, they would bring the information from that's provided through the clinical outcomes through to their independent clinical supervision, and the idea is that they focus on the clients who are showing no improvement or very little improvement. So again, it helps shape and it helps focus their development, and that's very much the ethos that they've bought into.
Okay, so it's a collective culture in which people are feeling that they're contributing to an organisational goal to reduce loss of life to an absolute minimum, and therefore they see those data being used not only to secure funding for the service to continue to survive and help others to survive, but also to be able to bring the correct data to supervision, to discuss, and to get help with clients that don't seem to be benefiting or improving service provision.
It's also a very useful way for us to be able to really narrow in what particular clients or client groups or presentations are we very good at working with, because we don't necessarily need to give too much attention. We're providing a very valuable service to a particular client group. We need to focus our energies on the clients that don't seem to be showing improvement either collectively from the service that we deliver or individually by a counsellor. So again, the data allowed the counsellors as individuals to be able to say, I'm really good with working with a 50-year-old female with X presentation. However, I don't seem to be able to see much change for the 16-year-old males with X presentation. So again, from that perspective, it really helped us to zoom in on what development individuals and the collective service could benefit from.
Brilliant. Obviously, I have to declare my bias, but I think data used in that way so richly to create a win-win for clinicians and indeed for service users to focus the resources on the service, on those that can most benefit from it, to learn from people that are not being helped consistently is exactly what practice-based evidence is about. And I may well be biased, but I think that you're a champion for that, and excellent. Are there other panelists with experience of other measurement systems and other types of data that equally have experience of using data in such a rich way to infuse, engage, and excite and learn from people?
We've been using the LQ as the backbone of the Chroma system within the Canadian Veterans Affairs system, and it's basically put to the clinicians in three ways in terms of its potential value. First of all, there's the multiple RCTs that demonstrate that it does have the potential to directly benefit that particular client in that session, which is nice. Number two, it also allows them, by use of the software dashboard, to keep an eye on a large number of clients and to focus on the vulnerable, which helps them to manage their time. The third thing that is helpful is that we use it to get the message out about why our programming is necessary. Just very briefly, we work with a trauma-heavy population, and typically the person comes in, they're briefly stabilized, they get one or more doses of evidence-informed treatment like prolonged exposure or CPT. And when the program was originally planned, that was supposed to be it. The thing is that we noticed pretty quickly that a lot of people hadn't changed an awful lot during that time, and a lot of clinicians continued with their clients for very long periods of time. What we did about a year ago was to monitor the outcomes and to split them out, treatment phase versus what we would call the recovery management phase, which is what comes after the long-term low intensity period. And what we're seeing now is that we get more reliable change in that recovery management period than we see during the quote active treatment period.
Mm.
This is helpful for us because we are being watched by everybody and their dog, from the government to the Treasury Board to veterans. And the point is that somebody was going to be evaluating it. So the message was, if we design the system ourselves with your input, then we have a better chance of getting it right. And that message seems to have really caught on in the last couple of years.
David, I think, again, those are extraordinarily rich and valuable lessons, learnings from the clinical coalface. What you're reflecting there is that lots of people do not change. And that is a reality that we see in practice-based evidence that we find many hypotheses for, etc. What you're doing is a very pragmatic solution, and you're finding a way, which is very difficult logistically, to follow up patients and clients after their treatment into a recovery management phase. And what you're finding is that there is more change in that recovery management phase after therapy than there is within therapy. And I think that's an absolutely key take-home message for the audience today, and perhaps something that people may want to be picking up with questions for Sam shortly, etc. Again, I'd like to use the next 10 minutes just to gather a little bit more of a richer experience from our panelists, and are there any other people that again have got examples of how they're using data in a way that is rewarding and reinforcing to the effort?
So I think
I'd like to share. Sorry.
Oh. Sorry, but
can I take names? Sorry, could I just take the names here of the two people that are trying to contribute, so I make sure that we capture them both? I can hear you're both male.
Yeah, it's Kim from Cuba.
Kim from Cuba, and the other person?
Odin from
yeah. Okay, thank you, Odin. I'll take both of you, but perhaps Kim first, if I may.
I think that what we've been working really hard at in Denmark and Cuba is to use the data not only to say to the contributors and so on why do you need to contribute to keep on contributing to Cuba and to Cuba's work, but also to let our therapists know that working with the data from routine outcome measurement actually allows us to learn something new about our clients, about the segment that we work with. And a lot of our clinicians have been really grateful that we've now been able to produce knowledge about how many young people between the age of 14 and 35 who grew up in families with alcohol abuse are actually depressed when seeking help in Cuba. And we thought that that number was way, way lower than it actually turned out to be. Almost 60% of the young people coming to Cuba have depression symptoms when they come and they start therapy with us. And that means that our clinicians are now able to focus on that fact that even though they're not realizing it from the beginning, they might have some underlying symptoms of depression that you need to be aware of when working with this target group. So we're trying to learn from the data, and we're trying to explain and give that knowledge to our therapists. And they've actually opened up in a good way and saying, this is very helpful for me when I work with the young people who come into my office for the first time.
That's excellent, Kim. Again, thank you very much indeed. So I can just summarize there what Kim's saying. We heard from Carrie earlier that as an organization, they're aware that sadly they lose about 30% of the lives of people coming to them each year as a suicide service. They're using those data as an organization to understand who they can help, who they most effectively can help, and targeting their resources on those people and using the data in supervision to do that using core data. Kim is using the RS, SRS, as well as a range of other measures, and again asking a question as an organization, who should we be targeting our resources at? Who are we most helping? Who are we least helping? That's not only as an organization, but Kim's talking about using that as individual clinicians and thinking about individual clinicians' strengths. Where do I consistently find that I'm supporting young people that are coming to work with me, or working groups that I'm delivering, etc. And I think both of those are really excellent examples of practice-based evidence having real value at the coalface. If I can move on to Auden, and then I've had also Ben has asked if he can share something as a panelist as well.
Yes, I just wanted to share some of our experiences in the implementation process. My thoughts probably address all three of the different areas of resistance you mentioned, John. I hope that's okay.
Yes, certainly, Adam.
Yes, I'd like to repeat that our experiences are from a group-based outpatient clinic where treatment primarily is delivered in different treatment teams. And we have, in retrospect, identified some steps that have been important to us in this process. And these steps, I think, have been important in dealing with the challenges later on in the process, or even avoiding some challenges. It's basically about building a solid foundation for the implementation process. So the first step for us was, of course, to get approval from the manager at the clinic and also arouse his enthusiasm. And the scatter plot was a way to catch his interest. Was a relevant way to catch his interest. In our experience, the scatter plot is the most widely used tool for managers and directors, probably because they face demands from the health authorities here in Norway to show that the treatment we deliver has effect. So we had to get our leader on board and ensure his support. The next step was about tailoring the use of routine outcome measurement to one of our treatment teams. So it became our pilot for the implementation. So initially we did careful preparations with the team. What did they need? What made sense to them? And we had to ensure user-friendly solutions and then ensure that the routine outcome measurement data could easily be incorporated into clinical situations and decisions. The third step was to assign a champion on the team, and he as well was a member of the team. So the champion is a person who has the role of being an ambassador, in this case for routine outcome measurement, and the task of promoting the use of ROM and underline the benefits by using it. So for us it has been crucial to run an initial pilot, he said, because it has led to favorable accounts of the use of routine outcome measurement, and interest from other treatment teams, and a demand for implementation of routine outcome measurement in other treatments. They wanted to show the effect of their treatment programs as well. So regarding implementation through teams, perhaps it's less frightening to monitor effect of treatment delivered in teams compared to individual therapy.
Again, Adam, I think that they're excellent points, and what you've really been talking about here is ensuring that you get buy-in across the group. First of all, making sure that the manager is fully in approval. You talked about the scatter plot and how that engaged his interest. For those in the audience that are unsure what we might be referring to, a scatter plot is simply a mechanism for putting a graphical a graphical representation of a cohort of clients. In Audun's case, clients that are in group work, making each dot represent a single patient and where they are in terms of their journey towards change. So typically scatter plots using this sort of approach, and many of the people here are using them in many different systems, would divide patients up into clinical and or reliable change, either showing statistical improvement or clinical recovery. Those that are showing no change, which is often up a tram line, the diagonal of a graph, where there is no meaningful change happening, or reliable deterioration where scores have actually worsened. And actually managers, supervisors are particularly interested in helping clinicians, helping teams, helping group work to identify those clients who may be on the deteriorated side of the scatter plot, to be able to quickly identify them, talk about them, and review how they may be helped. The other point that Audun's making is that they're starting very small, they're tailoring what they're doing to a single group, to a pilot, and getting a champion, and therefore what they hope to do is to create a positive culture by showing what is possible and by creating a culture of success. And that is a very, very successful way that I've seen in several implementations of starting. You start at the point of least resistance to get the people that are most enthusiastic and give a lot of time and effort and resources to them as internal administrators, as researchers, to help them succeed in achieving what they hope to achieve through measurement. And I think Kim was making similar points at Tuba as well. And the role of a champion really cannot be underestimated. I've also just had quickly a comment in from Carrie that we really shouldn't underestimate the power and indeed the role of the client to engage clinicians and engage managers in this process. She's reminding me very much of not only their own experience but a couple of PhDs that I've certainly supervised over the years, which have been both quantitative and qualitative, looking at clients' experience of routine outcome measurement and therapists' experience. And generally, and interestingly, clients are much more positive about the feedback from routine outcome measurement and value it greatly in the metaphors that they use, etc., relative to clinicians who are a little more hesitant as to its value, its meaning, and ultimately its utilization. So that just reminds me of very much the affirming and reinforcing and rewarding role of the client as a contributor. I have got also a note in from David that he'd quickly like to say something. David, if you would be quick, because I'd like to open it up to any questions now that might have come in from our audience and pass on to Sam. So if you could just restrict comments to no more than a couple of minutes, if you would. I think there's some confusion there. It's not David that wants to have a quick word. It's Ben. Ben, if I may invite you to say the last couple of words on this subject, that would be great. But if you could keep it to a couple of minutes.
Oh, sure, John. Yeah, no worries there. Yeah, just a couple quick comments on use of data. You know, I think when we do therapy, we often talk about bridging with our clients, meeting them where they're at. And my thoughts here really build on Audun's comments, especially. One of the things that I think we have to think about with routine outcome monitoring more in general is really bridging with clinicians. The vast majority of clinicians are effective in what they do, but their initial response of is being evaluated. One of the things that has really changed the nature of momentum in our project nationally is that our recent research has shown that the services in the naturalistic environment across the country in the U.S. are equally effective to RCTs, benchmarks for depression, generalized anxiety, etc. And when we communicate that to clinicians, the level of validation in the room and the level of buy-in to participating is just phenomenal. So I think one way to think about buy-in for clinical tools, use of clinical tools, is to demonstrate to some extent what clinicians already know, that they are effective with many of their clients. Two other quick examples that we have found to produce buy-in is training supervisors on how to use the instrument, repeated measures instrument, in supervision as a framework for discussing their clients. This makes the supervisor a teacher of the instrument, and then the supervisee a student of the instrument. And then we also try to have staff discussions where individual staff members will bring a profile report of the CCAPs and talk about that case, what fits, what doesn't fit, what's captured, what's not captured, and that invites just a wonderful discussion that further creates more buy-in for using the instrument.
Fantastic, Ben. Those are really helpful comments. Again, you've reminded me of a study that is, I think, just being submitted at this moment in time, which was a study that asked the question, if supervisors are given access to tracking data, then in a stepped wedge randomized control trial, would the outcomes of those, of the supervisees be better when the supervisors are getting access to such data than in the 6 months that they are not getting access? The results of the study were that actually there was very little difference in terms of the percentage of clients recovering or improving, but there was a very significant effect on the number of sessions that it took to improve and recover and get to that same amount. So again, I think it was highly supportive as to the place, the role, the value and potential of fit data, of ROM data being used in supervision, again, whatever the system that is being used. I think we have to end it there from our panelists' contribution and hand over now to Sam to pick up on any questions that may have been coming in. and I'd encourage panelists that perhaps haven't found opportunity to share their experience, particularly I'm thinking Tommy and Bill, who I know have got very, very rich experience to share. If there's something that you can find in these questions that resonates with your experience, then please I'd encourage you to participate and have your say today, because it's a very important experience that both of you have got.
Thanks, John. So in the interest of expediency, I think that we will not open up microphones because I have a number of questions in the queue and I'd like to get to as many of them as I can. And so unfortunately we won't have an interactive part to the panel today, but I think we'll get to more questions this way. So the first one is a question that really I think cuts across many of the topics that we've been talking about, which really is, given that there are 40 or 50 systems and measures out there that are commonly used in routine outcomes monitoring, what criteria really played into decisions related to picking one or another?
Well, perhaps I can come in here, but I have to...
Bill, if you're speaking, you're very faint.
Am I? Oh, is that better?
It's getting better.
Yeah, don't know what's going on here, but okay, so I think ease of use has got to be top of the list. Ease of use and flexibility of use. So having the ability to work with measures in a variety of different ways. So for example, with some environments, people have got to work with paper because they don't have internet access or whatever. But in other environments, they want to be completely electronic. So, for example, they need to be able to send a link to the client by email. So somebody's working by Skype, for example, or some sort of online system. So I think ease of use and flexibility of use are critical factors in decision making. And I think the best thing to do is to try a system first of all, and to make sure that it's going to fit. I like the idea of the pilot, a small pilot with a small number of practitioners, and testing out to see what's going to work best for them.
Terrific. Thanks, Bill. Anyone else?
I can offer
for us, the costs have also been affected. Oh.
No, go ahead.
Why don't we do Kim first and then Ben?
All right. So for us, the cost of the instrument has also been a factor. If you're a large organization, then license costs for some instruments will automatically rule them out. For instance, the STL90, which is about €2.50 per measurement, in the Netherlands was too expensive, and but it's obviously not the only criteria. Then the quality of the instrument, how well has it been validated, which is particularly true, I think, for us. Being a small country, not all instruments have been equally well been validated in our country, and very often people lean on the results in a US or UK population, but we know that Dutch people tend to score somewhat differently than Americans and British people. And so that's a criteria for us as well. And then obviously how well does it fit the population that you're working with, which should go first, and it is a very important thing. So we've worked with different instruments for different populations, depending on whether you expect the population to change in symptoms or whether you're more interested in quality of life. For instance, with severe mental health patients, that would be more of a focus than changes in symptoms.
Thanks, Kim. Ben, go ahead.
Yeah, Kim's comments really captured much of what I might say. The one thing I would additionally add is, if you're implementing an instrument in a large system, the ability to modify that instrument over time to match the needs of the infrastructure can be important. So proprietary instruments can be a challenge there, and if you have the abilities to sort of develop an instrument to fit your population, kind of as Kim was already discussing, that can be a real benefit.
Great. So I'm going to move us on to the next question, because I want to try and get through as many of these in the queue as we can, and we have 5 minutes left. So the next question really is one that resonates with me a lot, which is that you know, some therapy orientations have a longer history of being really sort of designed to work with measurement. And one of the challenges for other systems is that they may be working with therapists who are largely trained in orientations that do not have this sort of strong culture of measurement. And so the question really was related to, you know, do people have experience with psychodynamic, psychoanalytic, humanistic, some of the orientations that are maybe less oriented toward measurement, and applying the routine outcome measures to those particular, with therapists of those orientation.
Can I add something there?
I'll maybe come in.
Tommy, was that yourself?
Yeah.
Yeah, please do.
Yeah, thank you. Well, we have a lot of psychodynamic therapies at our clinic, and this was one big issue, and about should we use sessional measurement, or is there another way around this to get good enough data quality? We had this discussion with the clinicians. And finally, we arrived at the solution that, as we usually have very long, or relatively long therapies, a year or so, we offer a year or two therapies. So having sessional measurements many were resistant for the idea, so we decided to use monthly measurements instead. And this seems to have appeased and made many dynamic therapists more happy with using the system, actually. So being able to adapt the implementation according to the needs of the context might be necessary or helpful.
Thanks, Tommy. Sam, there was somebody else, I believe, that was about to answer. And
yes, myself. Yeah, hi John. I suppose just in terms of modalities, our service primarily would deliver, most of our clinicians would come from Gestalt, humanistic, person-centered or integrative background. The modality that we actually found most resistant to implementing a clinical outcome measure was creative art psychotherapy, because it felt introducing some sort of a structured set of questions within the counselling session was very much outside of the ethos of the creative approach. So from our services perspective, we had to do a lot of work with that particular team to engage buy-in, to be able to engage with a clinical outcome measure. The other challenge that we've faced, and we haven't quite overcome it yet, is that 30% of our clients will receive follow-on face-to-face counselling or psychotherapy, but 70% of our clients, and we also want to be able to find a way to measure outcomes for them, their way of contacting the service is by hotline, by telephone, and that might be one-off, it might be longer term, and it's to find a way that we can engage them in a real time, every contact evaluation as well. So we haven't quite overcome that challenge yet, but we're hopeful.
Thanks, Carrie. And Sam, if I might just say something on that very subject. I'm actually in the process, early stages, of working up a research bid at the moment with a group of academics who share belief that actually what we need to do is to train measurement as a clinical skill, and to make sure that measurement is integrated into practice as a clinical skill. A colleague of mine, James MacDonald, wrote a very interesting paper last year on psychoanalytic psychotherapy and how measurement can actually fit very neatly into the psychotherapeutic frame. And that was quite a challenging paper that's been well received, and other academics that I've been speaking to recently are very interested in creating a series of training modules that fit measurement into some of the major values and processes of the major models of therapy. I just think that's worth sort of saying and sharing for those that might be interested in that.
So I noticed that we're losing some audience members, but I do want to get one last question in because I think it's an important one and one we haven't touched on yet. And then we'll end. And if people have additional questions, there is in your invitation, there is a link that you can ask questions. You can email them. They'll come to me, and I'll make sure they get out to our panel so that you can get further responses. But the question, and it was directed toward Audun, but I think is a more general question for the panel, really is how does the implementation process differ and the utilization process differ for routine outcome measurement in group psychotherapy?
Just very briefly, in the VA clinics, we've been using the OQ45, the individual version. We are running more and more groups, and now we are looking at using the group version that's been validated by Gary Burlingame specifically, so we can track from session to session, because otherwise it's just pre-post for us.
Other thoughts about using outcome measures in groups?
Yes.
Yeah, we're using the FIT system in Cuba, and we're using the GSRS, the group SRS. And one of the things our therapists are giving us feedback on is that it's actually helping them discovering the clients in groups who are holding back and aren't really saying what they want to say, because they might have difficulties explaining themselves and getting the right words out when sitting in groups with others. So it's actually helping them to have focus on those clients who might need a bit of help in explaining their problems to others. So it's helping them actually. Yeah.
If I may add to that, we've been developing a feedback tool for group psychotherapy, because one of the things that we ran into when we wanted to do these measurements in groups, and we're using the individual version of the OQ45 for that, by the way, is that therapists may have feedback on about 8 patients, and so before the group starts, especially if you're measuring session by session, it's quite complicated to get that kind of overview. And so we've created an overview for them that sort of highlights which patients compared to the last sessions have had negative change, and also compared to the first session. And then we also map their progress graphs all in one graph, so that it's easy for them to look into sort of how patients are doing. The other thing is that we've been working on creating clinical support tools also for groups, which means that if a patient is not progressing well, additional measure is being given to the patient that measures group cohesion, the group version of the alliance, and so a couple of things that may sort of be helpful in helping that patient fit into the group in a better way, or at least provide the therapist with some ideas of what he or she would be able to work with.
Terrific. Thank you, guys. To those audience members whose questions we didn't get to today, I apologize. We had a lot of really great questions coming in, and I wanted to make sure that we got to at least one question from most of the people who were asking them. I want to thank everybody for participating, thank our panel, and thank our audience for your engaged questions and for attending to this hour-and-a-half presentation. Like I said, if you have further questions, feel free to click on the email link attached to your webinar invitation, and I will field any questions or comments that you have. If you do have feedback, we'd love to hear that, and I'll make sure I get positive comments out to the panel as well. John, any final words?
Well, just really to thank each of the panelists individually. It really couldn't have happened without you today. I hope that this is just a start of a sharing journey and the potential of a learning collaborative, as we like to now call them. And I would like to think that we may be able to capture each of your stories in a special edition of some journal at some point to share the rich learning that you bring. There was a limited opportunity to share the depth of it today. We've scratched the surface of it, but even as a surface scratch, I think it was incredibly valuable. And well, thank you guys for everything that you're accomplishing in introducing routine outcome measurement and showing that what many people think is impossible really is possible.
Well, with that, I will conclude the webinar. This will be available online on SPR's website. We'll likely also make it available through CEPI and APA Division 29. Thank you, everybody, for your participation. And
Sam, thank you for you today, because without you, again, this would not have been possible. It was your suggestion, and you've moderated it brilliantly. And thank you from the panel and from myself for the hard work that you've put into this. It's been well worth it.
Well, thanks, John. It's a real pleasure to be able to reach out internationally like this and stimulate some conversation. So let's make sure we get lots of follow-up, and thank you all again for participating. I'm going to end the webinar now for everybody.
Thank you. Bye now.